Great. Thanks, Sarah. And thanks all for your attendance today. I'm really, really looking forward to this session. I hope that what we discussed today is helpful and informative and interesting. So Sarah mentioned, my name is Derrick. I'm a principal investigator at the Institute for Psycholinguistics and Digital Health. And one of the goals of the Institute is to identify new and promising treatments, to evaluate their effectiveness, and then to try to understand some of the mechanisms of change behind, excuse me, some of the mechanisms of change behind these interventions. So that's what we do. Been very fortunate to work with the group that's provided this data called MindBloom that provides at-home sublingual ketamine treatment. And looking forward to sharing more of what we found in this very interesting intervention today. So the reference is there at the bottom of this slide for those who are interested, although Sarah already mentioned it in the intro, so thank you for that. Excited to share a little bit about the delivery model. So the delivery model is entirely virtual. It didn't start out that way. Pre-pandemic, there was a clinic where individuals would come in person to receive the treatment. But when the pandemic broke out, there were lots of barriers to receiving all kinds of care. And one of the innovations that was attempted here was to provide treatment at home. So a clinical evaluation is done virtually on the current model, and a prescriber, typically a psychiatrist, sometimes a psychiatric nurse, will meet with an individual to evaluate where they're at, make sure that the treatment is suitable for them. And there's a whole host of exclusion and inclusion criteria for the treatment, which are given in great detail in the paper, so I won't revisit them here. I imagine many of you are delivering this kind of treatment. So all of the counter indicators that you would use when determining whether a patient's a good fit for this treatment are used in this model as well. It's also an opportunity for the prescriber, for the clinician to get to know the patient, get a little bit more about their background, what brought them to treatment, what are they hoping to get out of the treatment, have they had experience with this form of treatment before, what are their expectations, all of that is sort of covered in this initial evaluation. Once they are found to be a fit for treatment, they take the baseline measures, and I'll discuss those more here, but they're the sort of standard depression and anxiety measures, the GAD-7 for anxiety and the PHQ-9 for depression. And there's a host of other measures that they take as well. There's a suicide measure that's given at baseline. There's questions around substance use, alcohol use, and a host of other measures. In the talk today, I'll be focused primarily on the outcome measures, but the paper does provide data around some of the baseline means and standard deviations for the other measures that I mentioned. Once we have established a baseline, in the first week, they're sent a single dose of sublingual ketamine lozenges, and the dosage is geared to, a desired outcome for the treatment and relative to their weight. It's not just their weight, because as we know, ketamine, you can ground it based on weight, but that isn't always a perfect measure. So the idea is to send them a single dose in the first week to sort of establish a baseline, see how effective that dose was, and then the dose can either be increased or decreased for subsequent sessions. After they have the first medication session in week 1, they have an evaluation afterwards to see how it went. The clinician then makes a decision about whether to maintain that dosage or to modify it in some way. And then the remainder of the medication is sent for the treatment, which would take you through weeks 2 through 4. So a week 2, a week 3, and a week 4 dosage for medication sessions. Outcomes are measured at week 2, and then outcomes again were measured at week 4. And throughout that time, the patient's having an interaction with the clinician remotely, and also an interaction with guides that provide psychosocial support. They help the individual get set up, make sure that the blood pressure cuff that was mailed to them is working, make sure that they got the other materials like the journal, any anti-nausea medication if they need that, have it on hand just in case, and other aspects and other materials that are important for the treatment. And they're also there to provide support throughout the treatment. So if an individual encounters an issue or has a thought or something that they would want to process with somebody, the guides are there to provide that kind of support all the way through. And that also starts in week 1. So that's a week 1 through week 4 service that's provided by the guides. And then at week 4, as I mentioned, we get the final outcomes. And at that point, a disposition is made for the patient to either continue or to stop treatment. And that's made collaboratively with their prescribing clinician and other members of the staff. And many individuals do choose to go on, but for the purposes of the talk today, I'm going to focus specifically on the first 4 weeks. How did we select data for the study? Let me just move my thing up here. There we go. So we started out by assessing everybody who would have had a full treatment course from the time that this treatment was offered in January up through roughly October, November of that year. And there were thousands of individuals who have received this treatment. So we reviewed cases there. We excluded just 28 for whom they went through the intake. They were going to begin treatment, but then dropped out at the last minute and did not complete a single medication session. So we removed them. And then from there, we analyzed charts relative to, did they continue with the treatment or did they drop out? And any safety indicators. Did they contact the guide? When they spoke to a clinician, were there concerns about side effects? Were any of them admitted to an ER or hospital for follow-up care as a result of the treatment? Within that group, we limited the data set for outcome purposes, that is the PHQ-9 and the GAD-7 outcomes, to individuals who had at least 2 responses, so a baseline and responses at week 2. If they didn't have at least those 2 time points, we removed them from the analysis because it's difficult for an observational study of this nature to draw any conclusions for individuals who have only completed a single outcome measure at baseline or no outcome measures. And we brought them into the sample, and there was another drop-off for individuals who completed a baseline and week 2, but who did not complete a week 4, but we included them in the data anyway. And when I talk about the latent growth mixture modeling, which is an analytic method that we used, it's possible to impute certain kinds of data if it's missing, and also to have the algorithm classify them even if a single data point is missing. But we did lose some moving into week 4. So the primary sample of focus here was about 1,250 people. And then we'll see that there was about another half of that or so at week 4. And I should comment here that when doing it, this is maybe, I don't know, the 15th or 16th observational large scale outcome study that I've worked on. It's not unusual for individuals to not complete outcome measures. Unlike an RCT, you're not incentivizing individuals to complete outcome measures. So it's kind of up to them. So there's 2 important things to say about that. One is that in the supplementary materials of the paper, we tried to identify whether there are any systematic differences through sensitivity analyses between individuals who did complete measures and individuals who completed the first 2 measures versus individuals who completed the week 4 measure. And there were some small differences on like the alcohol use questionnaire, but for the most part, there was no systematic difference between individuals who completed 2 weeks worth of measures and individuals who completed the 4th week, which is nice. And the second thing to say is that data by John Kane and other groups have shown that when you incentivize the completion of outcome measures, you inflate engagement with the treatment, largely because individuals are continuing, for the sake of the monetary incentive, which sort of distorts the generalizability to an actual practice setting where you're not paying individuals to receive the treatment, but they're paying you. So we felt like there is a trade-off in these kinds of studies between data completion, which we have to sort of accept that not everybody's going to complete the measures, but by not incentivizing them, it increases the inferences that we can make about how this would actually unfold in the wild, because we're not distorting the dynamics of the treatment through any kind of incentive to complete outcome measures. So I just want to highlight that. That's an important aspect of this kind of research design, and its strengths and limitations are important to bear in mind. So let's talk a little bit about the patient compositions. I mentioned almost 1,250 people. I don't want to go through this in too much detail. I think one thing to highlight that's particularly interesting is the mix of female to male. We see there are slightly more women in the sample, but a good number of men. We mentioned this in the discussion of the paper. If you look at other kinds of observational, mental health focused approaches to treatment, you often see a preponderance of women over men, sometimes 80 to 20%. So it's interesting that this is an approach to care that men find more accessible and more feasible for their situation. Of course, we could speculate about why that might be, and we do a little bit in the paper, but I think that's an important thing to highlight here is how many men are in this sample. We do see that the majority are still in an urban setting, although access to individuals in a rural area, at least in the United States, for something like ketamine treatment is unthinkable. So that there's even a 5% of individuals who are in more rural settings is an interesting win for this approach to care. And I think another thing to highlight is the dropout. In other studies where you compare a digital approach to mental health to more traditional approaches to care, you do tend to see higher engagement with digital forms. We think largely due to convenience, largely due to accessibility. It's so much easier to log on at home. In fact, many practitioners, you may have experienced this yourselves, when you move to video post-pandemic, many practitioners are surprised by how many more sessions are kept. People aren't missing sessions as much because of that accessibility. And you can see these really, really small dropout rates for this form of treatment are suggestive, I think, of convenience. I think there's also something about the novelty of it as well. It's a new form of care, and there's a kind of novelty effect here where people are especially excited about a new approach to delivering care. So that may explain this really small dropout. Hopefully these low levels of dropout will continue. That's what we would hope for any treatment, of course. Now, if we take a quick glance at the outcomes for depression and anxiety, the first thing you might be asking yourself is, well, Derrick, I thought you said that there were 1,250 people in the sample. How come there's only 989 baseline PHQ observations? The quick answer to that is that what we did for the 1,250 is anybody who had a score of 10 or higher on either the PHQ or the GAD-7 was included. That's an important inclusion criteria. So that doesn't mean that everybody had baseline PHQs above 10, but the 989 did, and then 937 had baseline GAD-7 observations of 10 or higher. The baseline average, is about 15 for both measures. Now, if you look at research on, say, intravenous ketamine, typically you see baseline scores of closer to 18. So this is a slightly more mild sample than you might see in a standard like RCT for ketamine treatment. However, a score of 15 is still in the moderate to moderate severe range for depression and anxiety. So these are significantly impaired individuals who are suffering. And by session 4, we see a 50% reduction on average for virtually everybody. The effect sizes are quite large, especially by week 4, 1.6 and 1.6, or 1.6 and 1.56 for anxiety. These are about on par for what you see in RCTs that are reported for RCTs for intravenous ketamine. So that's a nice comparison to make just to get a feel for the effects. The other thing I think that's important about this effect size is that these are individuals who are receiving care at home. And sometimes when you have a research team that's lavishing you with attention and is taking you through all the rigor of an RCT, there are some individuals who would argue that that would inflate outcomes, whereas these are individuals who are just at home. So it's nice to see that the outcomes in RCTs translate nicely into the quote unquote real world in this kind of data set. And the response rates are high. Again, similar to what you would see for intravenous ketamine, maybe a little bit higher than what's reported, but definitely very close in the same range. Certainly higher than what you would see for a psychosocial intervention, particularly in just 4 weeks, and typically much better outcomes than you would see for SSRIs alone. If we go a little bit deeper to look at the remission rates are quite high. And by remission, we're talking about a very strong outcome. These are individuals who have scores less than 5 on the PHQ or the GAD-7. So virtually no symptoms at all. And about a third of the sample experienced that by week 4, which is remarkable in 4 weeks. Clinically significant change. If you have questions about that, I'm happy to say more about it. It's similar to a response rate, but has slightly different criteria. But the numbers here are very similar to what we saw on the response rate. And fascinatingly, the number of individuals who deteriorated is quite low in this treatment. I have thoughts about that. I'm going to save them for later. We'll see if there's questions around it. Typically, like if you were to look at, say, a psychosocial intervention in a large data set like this, you would expect to see anywhere between 6 to 7% who would deteriorate on these measures. So this really low deterioration rate is sort of fascinating and something that could be good for a follow-up study to understand what exactly is driving that. Suicide ideation is interesting. There's increasing literature and research to suggest that ketamine is helpful for reducing suicide ideation, whether administered in an emergency room, hospital setting, or even in an outpatient setting. And here we see a significant reduction in suicide ideation over 4 weeks. I think this is fascinating. I think it's suggestive of this approach to care for suicide ideation. The downside to this data is it's just a single item on the PHQ-9. And as you can see, the item reads thoughts that you would be better off dead or of hurting yourself, which captures a wide range of suicide ideation and suicidal behavior. So, you know, we may not be super duper happy with the way that this item reflects suicide. It might be better maybe to have like the Columbia suicide scale to really dig into its impact on suicide. But again, it's observational data. Everything that we're talking about today is a first cut. It's, you know, it's to help us ask more questions, which we'll be excited to do with these data. Let me talk a little bit about the latent growth mixture model that we put together, because I personally think that more outcome researchers, especially when working with real world data and large data sets, should use this approach. The head counting for response rate and clinically significant change and deterioration is okay, and that's fine, and those are measures that we're all familiar with. But latent growth mixture modeling is a more sophisticated way of breaking the data set up into different kinds of trajectories, different kinds of subpopulations. It's highly unlikely in a large data set that you would just have a single normal distribution that would reflect, you know, the average population. Instead, there's probably subpopulations within that large data set. And this graphic here helps to show the way in which latent growth mixture modeling identifies distributions that are hidden within the larger distribution, so that you can pull out qualitatively different kinds of groups and look at their outcomes. The other upside to this kind of modeling is that it's, you know, it's fine to see that an individual's symptoms are going down over time, and that's a first glance and an important first approach to understanding how effective an intervention is. But what predicts that improvement? What characteristics describe the individuals that are experiencing that kind of improvement? And I think latent growth mixture modeling is a powerful way to answer those kinds of questions, because they have clinical implications beyond just, you know, 80% of people get better, 60% of people get better. These are the outcome trajectories for both the PHQ-9 and for the GAD-7. We found 3 different subpopulations. The first is a group that starts, as you can see, if you direct your attention to the left-hand side of the screen for depression, you see they start at about a 15, so in that like average range, and they end at about a 5, which is, again, very strong outcome. And they improve consistently and rapidly in the first 4 weeks. The second group, which is the blue line, improves very little in the first 2 weeks and then improves rapidly from week 2 to week 4. And I'll discuss why we think that might be. And also, I'm sorry, I should have mentioned before that the percentages up above that are matched to the color tell you how many individuals in the sample are characterized by this kind of outcome. So we see that 80% improve consistently and rapidly through treatment, so the vast majority. The delayed improvement group that I just described, almost 10%. And then there's another 10% who improve a little bit, but more or less take a pretty chronic course. They start somewhat severe, they end about moderate, not the kind of outcome we would want. But we know in any kind of intervention, not every patient's going to have the ideal outcome. It's just a question of which percentage do or which don't, and then what to do with them afterwards. We see very similar groups for anxiety. Again, a chronic group, a delayed improvement group, and the central improvement group, which made up the majority of this sample. So what differentiates these groups? And this is where latent growth mixture modeling, I think, is really helpful, because you can look at odds ratios that can give a little more insight into these clinical populations. So the first thing to mention is that those individuals who are more likely to be in the improvement group relative to the delayed improvement group had higher dissociation scores at week 4, which is interesting. And you know, there's a debate in the literature around how important is dissociation, how important is the psychological effects of ketamine for having the outcomes that are observed. And some people find that dissociation is very important, and in other studies, they lose the effect. And the reason I'm belaboring this a little bit is because I think these data may help to explain why sometimes there's an effect and sometimes there isn't. So the first thing to sort of hold in your mind is that you're more likely to be in the improvement group if you have higher dissociation at week 4. You're more likely to be in the delayed improvement group relative to the improvement group if you have high side effects at week 2. So that gives a little bit of insight into if individuals are struggling with that first dose of ketamine in the first 2 weeks, it may take a little while for the symptoms to catch up with the improvement group. And I have a list of the different side effects that are reported in the lower right-hand side of the screen. So you can get a sense of, you know, these are the sorts of side effects that are expected for a ketamine treatment. And I think clinically, what's important to highlight here is that if somebody's having side effects in the first 2 weeks, it doesn't necessarily, and if you were to track like PH2 scores, it doesn't mean that they can't still benefit from the treatment if they were to continue for another 2 weeks. And I think these data are very strongly suggestive that side effects, as long as, of course, they're tolerable and don't lead to hospitalization and are not damaging the patient in the view of the clinician, are not necessarily a barrier to improving in the treatment and continuing with the treatment. And then thirdly, you would be more likely to be in the chronic group than either delayed or the improvement group if you have higher suicide ideation at baseline, which sort of makes a kind of sense, and if you have higher dissociation at week 4. So this is where the dissociation conundrum may be. Maybe we can shed a little bit of light on that, because you're more likely to improve if you have high dissociation at week 4, and you're also less likely to improve. And so there are some individual differences for how dissociation is playing out in terms of outcome here that would be interesting to continue to investigate. I mentioned the data missingness. Let me mention some other limitations here. So obviously this is an observational study. It's not an RCT. We're not randomizing individuals. These are individuals who have sought this treatment. So there's selection bias. And we know that individuals who are motivated for treatment tend to do better than individuals who aren't. So bear a lot of that in mind when we're looking at these observational data. Of course, data missingness is another issue. And there are other inferential challenges when working with observational data like this. There are RCTs and other follow-up studies in plan, not just with our group, but with other groups. And we look forward to continued investigation of this approach to treatment. And then the last two limitations, I think, are, well, I mean, so treatment ends at around week 4. We don't have any treatment data after that. I mean, with these kinds of populations, it's hard to know whether they would complete those measures anyway. But there is a strong desire to try to get this kind of post-treatment data to look at durability. So typically when you look at durability in like a ketamine intravenous care, you can see a quick drop off in the effectiveness of the treatment after a week. I mean, that is, if you have a single ketamine infusion and then no others following that, there's like an increase in functioning and then a decrease that follows. So already we have a kind of test of durability in these data because it's taking place over 4 weeks instead of a single intravenous session, although I know more and more practitioners are not just doing single session treatments. But more importantly, if somebody were to not have a ketamine treatment for 4 weeks, 5 months, 12 months, how durable are these effects? And that's information we don't have currently, but would love to gather and to investigate. How long lasting are these effects? I think that brings me pretty close to my 20 minutes. So let me end there. I want to give thanks to all the other co-authors, many of whom are experts in ketamine care and other kinds of psychedelic treatments at Cleveland Clinic and a host of other places, MAPS institutes. So I want to give them thanks, and also thanks to Mindbloom and Dylan, who leads the team there, for letting us have access to these data. Sarah, shall I stop for now and see how the questions come in?
Yes, thank you very much, Derrick. It was a terrific presentation, and we already have so many questions in the Q&A. So I think maybe what I would suggest to do is we can maybe start with a couple of them, and then we can stop the recording and promote everybody to panelists, so we can have a bit more interactive discussion, if that sounds all right.
Yeah, can't wait.
So we got a couple of questions, two very similar one that I thought we could maybe start from there, sort of addressing the elephant in the room. He's one from Julia and one from Joy. So Julia is asking, what are the clinical implications of more than 50% with missed follow-up data? Is there a concern these patients had bad outcomes that weren't recorded, or misused ketamine? For example, took all the doses and stopped following up? And Joy, very similar, ask if you can say something more about the 1573 excluded participant. Can you please further characterize them, and how might this low 44% level of engagement bias your results?
Yeah, okay, so really important question. So thanks to both of you. The quick answer is it's not clear, because one of the things when you don't have data is it's hard to know what the data would have told you if you have it. One of the things we do have, though, is even if a patient is not completing outcome measures or the dissociation measure or the side effects measure, we do have notes that are taken by the clinicians in the electronic health record. And as I mentioned before, we did look at the electronic health records for all individuals, even if they didn't complete the week 4 outcomes. We didn't find any differences in terms of adverse events that were reported, or termination of treatment or hospitalization or anything of that nature. Now, is it possible that the individual, some of these individuals completely disappeared and there would be nothing for the clinician to put in the note? That's certainly possible. And what that leaves us with, though, is in the data that we have, there's no strong evidence that there was a huge difference in outcome or difficulty tolerating the treatment between individuals who completed week 2 measures and week 4 measures. I would say, to give a heuristic, that maybe 80% of the individuals who did not complete week 4 measures just lost interest in the outcome measures, didn't see what the purpose was, wasn't clear to them how it was integrated into the treatment, and just stopped. And that leaves a minority for whom we just don't have data. Did they have bad outcomes and leave? Possibly. These are things that we would want to look at in a future study. It's hard to know for sure right now. And in the future, if we were to do a more rigorous study here, clearly you would want to have closer follow-up and track some of this. Now, to the second piece, could the missing data possibly bias the results? With observational data, I think the answer to that has to be yes, because you don't know who you're missing. Certainly, the willingness to complete an outcome measure could be a reflection of motivation. And as I've said before, we know that motivation has an impact on all outcomes in mental health care, regardless of what the form of treatment is. So I think if anything, the outcomes at week 4 could be biased up to some degree due to the particular enthusiasm of individuals for this form of care at week 4, or a host of other issues. That said, it is interesting, though, that even by week 2, the outcomes for most people are really strong. They're not as strong as they are by week 4, but you can tell that most individuals are experiencing significant improvement by week 2, which I think again suggests, as I was saying before, that if most individuals are having a good experience up to week 2, it's unlikely that a majority of them would leave the treatment going into week 4. Chances are many of them moved forward, but just lost interest in the outcome measures. But that's something that we would need to further investigate. As I said, is a downside to these kinds of data. So we take that one on the chin and we move forward.
Thank you. Thank you very much. So just to clarify, so these people, if they didn't have missing data, was there still a chance that they were still receiving treatment or no?
Yes. Yeah. So that's the thing. The thing that's tricky about week 4 is there's 2 reasons why they may not be completing outcome measures. One is they left the treatment. Although, as I said, we looked at medical records to see if there were any significant differences in dropout between week 2 and week 4, and we didn't find any. The second reason, though, is that they just aren't interested in doing outcome measures anymore. And as I said, we're not forcing them. We're not paying them to complete outcome measures. And some people just lose interest over time. And as in looking at other kinds of observational data sets like this, it's not unusual to see people, most people will do the baseline because they're excited and it's new and they'll do anything you ask. By week 2, about 50% of the baseline folks will complete a week 2, and then you lose another 50% going into week 4, and you lose another 50. You kind of see this until you finally find the tried and true who will complete outcome measures for years if you ask them to, but that's usually a minority of these kinds of patients.
Well, thank you for clarifying these. I think another question before we move to the more informal discussion is, Adriana was asking, there was no measure of treatment resistance prior to treatment start, or was it not? And to which I would also like to add, do you have any information about what kind of other treatment they may have been receiving from a pharmacological or psychotherapy point of view?
Yeah, that's a great question. Largely because, as you know, much of the buzz around ketamine and a lot of the RCTs that are focused on ketamine are focused specifically on treatment-resistant populations. We did have data on how much treatment individuals had leading up to this treatment. The more we dug into it, though, there's some complications there. One is determining treatment resistance is not always that easy. because individuals may have been in treatment before, but maybe they didn't really engage with it, and that's why they didn't get better. And it wasn't always easy to determine from the data the extent to which, did they really have a strong, say, 3-month psychosocial treatment course, or had they been on SSRIs for 6 months leading up to this? The data there wasn't always totally complete. The other thing that was a little complicated is it's not clear in these kinds of data how to reflect the impact of treatment resistance on these outcomes. The more we dug into that data, we sort of felt like it is an important and interesting question, but that we should bracket it out as a separate study. It would really justify a paper on its own, because 30–40% of individuals had suggested that they had been in treatment before, and lots of different kinds of treatments, lots of different kinds. So characterizing that, we just didn't have space in a single paper to get at all of that, but we hope to do that in a future study. Now, the implications of that, and maybe this is what the question's leading to, is we don't know for sure that there's an apples to apples comparison between this form of treatment and, say, IV ketamine in an RCT for treatment-resistant patients, who have like well-documented medical histories and so forth. And I think that's just, worth bearing in mind, that this could be a slightly different population than what's typically studied in ketamine. And maybe in the informal session, I would love to hear thoughts about, what do we think about that? Should ketamine only be reserved for certain populations? Or is ketamine maybe a way to help more people get better faster? I think these are questions as a field that we can be asking.